Welcome to the TCCC Plus course, Day 1, Module 9. Here we cover assessing breathing, treating an open chest wound, recognizing tension, and needle decompression as a protocol skill. A chest wound can look stable and then kill as the pressure inside the chest rises. But hold the right expectation. Most chest injuries need little or no emergency treatment, and only careful positioning and observation, not a procedure. The dramatic intervention is rarely the one needed, and it is often the one that gets people into trouble. When we assess breathing, we should be deliberate about it, not just guessing. Assess the rate, whether the chest rises evenly, how hard they are working, and how distressed they are. Use a stopwatch, as we tend to underestimate the respiratory rate by a worrying margin without an objective measurement. Note any visible injury, penetrating wounds, burns, bruising, and remember that blunt and penetrating chest trauma often end in the same place. Broken ribs can punch holes in the lung from the inside, so a casualty thrown from a vehicle can have the same collapsed lung as one who was shot. A flail chest is when two or more contiguous ribs each break in two or more places, basically cutting a section of the chest wall loose. You can see it move on its own, the wrong way, pulling in when the rest of the chest expands, bulging out when it falls. It looks dramatic, but the flail itself is not what kills. Underneath it is a bruised, bleeding lung, and that contusion gets worse over hours, quietly stealing oxygen. There is no clever fix here. Do not strap it down, that only splints the breathing you need. Position them however they breathe easiest, often the injured side down. Give oxygen if you have it, treat the pain so they can breathe, and reassess often, because this is a casualty who can look stable and then tire and fail. This is a sucking chest wound, an open hole through the chest wall. Normally, air only moves through the mouth and the windpipe. Here, however, it takes a shortcut, in and out through the wound, and you may hear it suck or see it bubble and froth as the casualty breathes. Every breath pulls air into the space around the lung. The lung is pushed down and collapses, and the casualty starves for air. Recognizing it is the whole job on this slide. The treatment comes next. You seal it, you do not pack it, and then you watch, because a sealed chest can build into a tension pneumothorax. An open chest wound is what it sounds like. A sucking chest wound is one where air is drawn into the chest through the wall. That air goes around the lung, not into it, and squeezes it. If the hole acts as a valve, the trapped air builds and gradually crushes the lung, then the heart and great vessels. That is a tension pneumothorax. Furthermore, we do not pack a chest wound, but seal it. Use a vented chest seal so air can leave the chest but not enter, which heads off a tension. A non-vented or badly stuck seal can itself become the one-way valve that causes one. If breathing worsens after sealing, lift a corner and let it out. Burp it by opening one side and closing it again, or trying to change it entirely or decompress the lung. Again, an open chest wound gets a seal, not packing. Cover it so air stops being sucked in through the hole. Keep watching for worsening breathing, because a seal can turn a simple open wound into a tension pneumothorax, so if the casualty worsens, burp it or replace it, or consider escalating.
Hey, it's Avery. I'm going to teach you how to apply a chest seal to an open chest wound, sometimes called a sucking chest wound, and monitor its effectiveness. As part of a rapid casualty assessment, you would expose the casualty's chest and back to identify penetrating injuries like entry or exit wounds. Assess breathing and look and feel for any wounds by running both hands across the chest and back using a sweeping motion. If you find an open chest wound, or if the casualty is displaying signs or symptoms of a penetrating chest injury, such as sucking or hissing, when the casualty inhales, or if they have difficulty breathing, stop the evaluation and locate the nearest first aid kit. In the kit, you will find a chest seal, which is an air and watertight adhesive dressing. There are two types of chest seals, vented and non-vented. The Committee on Tactical Combat Casualty Care recommends using a vented chest seal if available. This type of seal has been demonstrated to reduce the chances of developing a pneumothorax, which is a collapsing lung. Open the chest seal packet and remove the chest seal and gauze. Using the gauze, quickly wipe away any dirt, blood, or other fluid from the injury site. Prepare the chest seal by peeling off the protective liner. Whether it's a vented or non-vented chest seal, they are applied the same way. You must center the chest seal over the hole and apply, placing the adhesive side down, pressing firmly to seal the wound. If the casualty is awake, have the casualty exhale or breathe out before application. At the end of their exhalation, apply the chest seal. Check the chest seal to ensure that it extends at least 2 inches beyond the wound edges in all directions. Ensure all edges of the chest seal are flat and stuck against the skin. If tape is available, tape down all 4 edges of the chest seal to the casualty's chest. Repeat these steps to seal any other open chest wounds on the exposed side. Then, roll the casualty onto the opposite side and visually inspect the other side of the chest and feel with your hands for any additional wounds. Apply a chest seal and tape, if available, to all 4 sides of any additional wounds. After applying a chest seal, you will need to place the casualty in an optimal position depending on other injuries they may have sustained. Place a casualty that is awake in either a sitting position or the recovery position, depending on which they tolerate better. Place an unconscious casualty in the recovery position. However, if you suspect a head, neck, or spine injury in a conscious or unconscious patient, leave them as you find them on a hard, flat surface. Reassess and monitor the casualty for breathing every few minutes. If the casualty becomes increasingly short of breath or has difficulty breathing, this could be a sign of a pneumothorax, which must be addressed immediately. To relieve pressure that builds up in this type of pneumothorax, you will need to burp the chest seal by lifting one edge of the seal up, allowing any trapped air to escape. Clear any blood away from the area and reapply the chest seal upon exhalation. Alternatively, remove the entire seal for a few seconds to decompress the wound and reapply it or replace it with a new chest seal. If a casualty's breathing continues to worsen despite burping the chest seal, notify medical personnel immediately. Document all medical aid rendered on the patient's DD 1380 Tactical Combat Casualty Care TCCC card if available. Inform medical personnel of your findings and any medical aid provided and assist with evacuation as requested. Applying a chest seal can help restore a casualty's ability to maintain adequate respiration and is a critical skill that is part of the MARCH airway and respiratory management techniques.
Watch the chest seal go on. The skin around the wound is wiped as dry as the situation allows because nothing sticks to blood and sweat. The seal is peeled and pressed down flat over the wound, covering it completely, and a vented seal is preferred because it lets trapped air escape while keeping outside air out. Find the exit wound and seal that too. Then the job is not finished. Keep watching, because if the casualty gets worse after sealing, air may be building under pressure and you burp the seal or move to decompression. It is important to recognise respiratory worsening. Rising pressure in the chest shows as worsening respiratory distress, a climbing breathing rate, anxiety, and later a falling level of consciousness. A classic field tell is a casualty who can only speak in single words between breaths. Hypoxia and a fast breathing rate are the common signs. The textbook late signs, jugular veins standing out and the windpipe pushed to one side, are in fact uncommon, so do not wait for them. Treating attention is time critical. Evolution of the injury is usually why a chest wound turns deadly. Air gets into the chest through a one-way valve and cannot get out. Each breath adds pressure until it crushes the lung and the heart. Seal the outside wound, then watch. If pressure builds, you must let it out. Emergency treatment of a tension pneumothorax is needle decompression. This is usually beyond ASM and a deliberately blind procedure, so make sure you are authorized and trained if you are to use it. It will not be taught in the in-person modules, but is mentioned here for completeness. A large needle catheter goes between the ribs on the injured side to release the trapped air at one of two safe sites. The fifth space in the anterior axillary line at the level of the nipple or inframammary fold, the fold under the breast, riding over the top of the lower rib, or the second intercostal space in the mid-clavicular line, again just over the top of the third rib. Go over the top of the rib, never under it, because the nerve and vessels run on the underside. If one site does not work, try the other. You should hear a rush of air when you are in. Sit them upright if you can and call telemedicine. It is a temporary fix, not a cure. The catheter can kink or clog, and if it fails or evacuation will be long, the definitive answer is a chest tube placed by someone trained to do it. As mentioned, we have two standard sites for decompression, and if you are going to use an NDC, you should know them cold. First choice is in the fifth intercostal space, anterior axillary line, which means about in level with the nipple or inframammary fold, the fold under the breast, and in line with the line going straight down from the front part of the armpit. The second choice is the second intercostal space in the mid-clavicular line. Feel the rib and go over the top of it, never under it, to miss the vessels that go on the underside of the ribs. This is how you release the pressure the last picture showed building. Needle decompression is an authorized skill, not a first move, and only for a casualty whose tension pneumothorax is killing them. You have seen where the needle goes, the fifth rib space in the line down from the armpit, or the second space down from the collarbone, always passing over the top of the rib, not under it. The trick in this video is the check. A syringe part filled with water sits on the needle, and as the tip enters the chest, you get a hiss and a stream of bubbles, air under pressure escaping through the water. That bubbling is your confirmation you are in the right place. No bubbles and no improvement means you may be too shallow or off the mark, so you reassess rather than tell yourself it worked. Decompression buys minutes, not a cure. The casualty still needs to move. To repeat the initial slides, despite a lot of dramatic interventions available, most chest injuries do best with nothing dramatic. Sit them upright, observe, keep them warm, control the pain. Again, the choice of interventions depend on phases of care. While under fire, breathing is not addressed. In tactical field care, we can start sealing open wounds, observe recognized tension pneumothorax, position the casualty upright and decompress if authorized. During evacuation, monitor the seal and the catheter and reassess. So let's look at common errors. A non-vented or poorly stuck seal turning into a one-way valve, air in, none out. Missing a slow building tension, and attempting needle decompression without training or authorization, and as in other cases, not reassessing. To recap, assess rate, symmetry, effort, distress. Vented seal on dry, clean skin, burp or replace if it worsens. Tension, worsening distress, rising rate, falling consciousness, one-word speech. Needle decompression is protocol only. Recognizing the problem is the ASM job. The procedure is by authorization. Thanks for watching our TCCC Plus for non-medics Day 1 Module 9 about respiration and chest injuries. Next up is Module 10, Circulation and Shock.